Can you see my screen? Let me know if you can see my screen, guys. Right. Okay. So today we are starting with our maternity two. About 2 weeks ago, we did maternity one. So today we're gonna start with maternity two. Uh, there is a live stream also ongoing currently on Facebook and YouTube. So you can share the link. Ayariga was share the link on the page. So uh, share it. It's a free class. Share it to everyone. Let them enjoy. Your colleague nurses. Okay, this is pure nursing today and healthcare. Okay, so share it to your colleagues. Let them enjoy. Mm, let everybody also enjoy and benefit from what you are receiving now. Okay, right. So we have about 2 minutes to start. We have about 2 minutes to start. Wow. I hope you can see this the words well. I want to make sure everybody can see it well. Let me also increase the volume. Okay. So today we are doing this pure. We're gonna look at ankles and also the more of maternal health. Okay, more of maternal health. Mm. The other time we started the pregnancy journey. So we did assessment. We saw how to confirm if someone is truly pregnant, where we look at the positive signs. Then we also look at the other signs, presumptive and probable. Okay. We did the pregnancy journey. We were able to assess our founder height. We were able to know the obstetric histories. Okay. Where we use the GT-PAL system, where everybody who joined is able to what calculate the estimated date of delivery. Okay. Then we look at the stages of labor, the first stage, second stage, third stage. We look at the fetal heart rate compared to the maternal contractions, where we look at the variabilities. Okay. Then, yeah, I mean, baby entering into the third stage. Okay. So today we are continuing. We are continuing with the pregnancy journey. It's a journey. If you don't understand it and you learn it anyhow, it will be difficult to catch the mysteries or the realities of it. Okay. So always make sure you learn maternity as a journey. Mm. Learn it
In progress.
as a journey. Okay. Right. So let's start. Time is up. You are spending the next 2 hours on this page. After that, we close so that you can get time to read, reflect, and refresh your mind. Okay. So let's look at fetal station. Fetal station. As you can see, you've seen a baby's head here and the pelvis of a woman. Okay. During pregnancy, this baby will go up. So assuming this is the whole abdominal cavity. Okay. So, and your umbilicus is here, and your upper abdomen is here, and this is your pelvis. Okay. So when we're doing fundal height, we realize that when you are pregnant, eh, from 0 to 9 months or whatever weeks we are looking at, okay, this head and the baby, it will go up. It will go up. So we look at what the fundal heighting here. Now, when it is time for the baby to be delivered from 9 months back to what a baby coming out, the hair of the baby will be descending down. It will descend down till it gets to the level of the pelvis of the woman. Okay, the pelvis of the woman. At this stage, we look at what we call station. What we call station. So the baby's head is descending down, going down, going down, going down until we get to what we call, you see all these pictures. The baby's head is going down, is going down, is going down until we get to what we call what the ischial spine. This one, this bone, the ischial spine. Okay. If you look at the top here, this is the ischial spine. Yes. So the presenting part of the baby, let's go and read the definition well, because a lot of people get it wrong. Fetal station describes the position of the presenting part of the fetus. That's the key word. The presenting part of the fetus. Usually, if you take 100 babies, 90 of these babies will come with their head. So we say usually the head, but you can see a baby that the buttocks comes first, the legs comes first, whatever comes first. Yes, that's the presenting part of the baby in relation to what? The ischial spine. So if I take the pelvis like this, and I take the pelvis like this, okay, and this is the ischial spine. If the head gets to this area, okay, the relationship with or the relation between this presenting part of the baby and this ischial spine is what we call what? The fetal station. And we have what? The spine is a bone, it's a big bone like this. Okay. The more you go down, this is the top. This is the bottom. So you are traveling from the top of the spine, the ischial spine, to the bottom. And the middle part is the zero. The central is the zero part, okay? So your head will first get to the top part here. And in medicine, we number them, okay? From the top to the bottom. It's like the number line. You remember the number line in primary school? So we have the zero. Anything after this zero or before this zero, sorry, is negative. So -1, -2, -3, -4. Okay, let me turn this number line and make it vertical like this. Still zero here. Anything before the zero is what? Is negative, negative, negative. Then after the zero, I become positive. Okay, let me take this number line to the pelvis of a woman and draw it here. And still put the zero here. Anything before this zero is negative. So if the head of the baby or whatever part of the baby that is coming down the uterus or coming out of the woman gets to this station, I'm looking at it in relation to a number line that you did in primary school. Okay, so if I have not reached zero, if I have not reached the 0 point, it means I'm still in the negatives. So at this stage, this baby is not ready to come out. Don't force the baby out. Okay, so mostly we look at it from -5 to +5. When I hit zero and I go down, anything after zero is positives. You are in the positive zone, so baby is safe to come out. That's it. I've simplified it for you. Any question? If you don't have any question, I continue. Today we are spending only 2 hours here. Or you can hold on with your question, write your questions down. When I finish, then you bring your answers, okay? Right. I want to make it so simple and easy for you so that you will never forget it again. So this is what we call fetal station. It is always measured in centimeters. Remember, we are dealing with maternity. So your measurements are always in centimeters, maternity. Okay. Now let's look at what? The landmarks. So I've spoken about the ischial spine. That's the 0 point. Okay. So everything above the 0 point is the negative. Anything below is the positives. Okay, let's go and look at the meaning, the interpretation. So you are carrying a baby, you went to labor, and the midwife told you that anti-AC. Let me get the list so that I can know people who are online now. Okay. So Beatrice, I'm seeing Beatrice now. Okay. So Beatrice went to the hospital. They told Beatrice that Beatrice, your baby is at the level of -5. Okay. The moment they mention negative, Beatrice should put in their mind that my baby is not ready to come out yet. Okay. The next 3-4 hours, we came to measure again. Still, baby is at what? -5. Meanwhile, the service is opening, but baby's head is stuck at level 5, -5. It means that the leak is not progressing because if the service is opening and the muscles of the uterus are contracting and they are pushing the baby down, why is the head of the baby stuck here at level 5? This baby is not progressing. Can we watch this baby stay here forever? No. At a point, the muscles of the uterus will get tired and they begin to go into what? Atonia. Atonia. When that happens, you can bleed. Okay, so when pregnancy is not progressing, we can give some uterotonics, some medications to give the strength of the muscles of the uterus to push the baby down. Still, if it is not coming, then maybe we have to go to theater and take this baby out. Okay. -4 to -3, you are above the midline, the ischia spine. Okay. So early labor, baby's head is coming down. Okay. -2 to -1, you are approaching what we call engagement. Engagement, yes. So you are approaching the zero line. That's what we are approaching the engagement, the midline. Look at the number line. Okay. Now your head is at what? 0. So here we say baby's head is engaged. The midwives will use the English engaged. I am engaging you. I am engaging you. Okay, so why the word engagement? Ayarega wants to marry his wife. Okay. This is Ayarega. This is Beatrice. They want to marry. They are from different families. Okay. Ayarega's families are here. And Beatrice's families are here. When during the day they want to marry, these two families will come together and they will come and stand behind, not in front. No, you've never attended any wedding that the husband will be here, the wife will be here, and the family of the husband are standing in front of the no, or the family of the are standing in front of the woman. No, they always stand behind, so that there will be a space in between the two families. And these two couples will be what? Married in between. So they will be engaged at this point. So comparing it or linking it to the number line or this filter station method, okay, we have the negatives and so I have the negatives and I have the positives. But in between here, at the zeros, that we call the engagement. So at this moment, the head of the baby is at this level. It is being engaged. Okay. Labor is properly and positively progressing at this stage. Okay. It's positively progressing. And every pregnant woman will be happy. So the midwives among us, please always talk to your patients. It's very important. Okay, now let's go to so as it is progressing now, maternal engagement is going to the positive. I like it. What the pregnant woman likes more is the +5, the crowning. It means VF is what? Imminent. Okay. Imminent. Don't go and give epidural at this stage. What stage do we give epidural? Who knows? Yes, we did the stages of labor. Stage 1. What part of stage 1 do we give epidural?
Active phase of stage 1.
Come again. The active phase. Okay. The active phase of stage 1. That is where we give what? So we are 0 to 3. 3 plus 4 is 7. So 7 is here. So 4 to 7, between this 4 to 7 cervical dilatation. That's the stage you need to give your epidural. Don't go and give somebody's pregnant woman epidural here or pain medications here. It won't help. Okay. So you know engagement now. I don't think you should forget it again. It is the widest part. It occurs when the widest part of the fetal head passes through the pelvic inlet. It corresponds to what? Station 0. Okay. It is more common before labor in nulliparous women and during labor in multiparous women. So engagement. So let's look at how station changes during labor. Station should increase. It should increase because you are moving from the negatives to the positives. Yes. So I have -5. If I add 1, I will move to -4. If I add another 1, I'll move to -3. I add another 1, -2, then 0 plus 1 to 5 plus 5. That is what we call improvements. Increase. They move towards the positive numbers as labor progresses. So, what happens when Ayariga's child head is at 5 and is not going +5? Something has locked the head or the presenting part. It has locked it here. What is locking it that the head is not descending down? It can be cephalopelvic disproportion. Okay. Ineffective positioning or malpositioning of the mother, the pregnant mother. Okay. So this is a patient lying by the side. Okay. Instead of the lithotomy position or whatever. Can affect that. It depends. Some pregnant women will lie by the side, babies will still descend. Some too, so try and change, do all these maneuvers, change position to see if the head will descend down. Then ineffective contraction of the uterine muscles. Remember, if the uterine muscle doesn't have strength, trouble has come. Okay, what will push the baby down? So you should do your assessment. The uterus is tired. Okay. Now going forward, those of you who are going to write NCLEX, there's going to be a warning for you. High station plus rupture of membranes is a risk for what? Umbilical cord prolapse. Okay. What does this mean? So a mother has ruptured membranes, maybe 35 weeks or 36 weeks, whichever weeks. This is the uterus. This is the pelvis. The head is here. This is the ischial bones, the pelvic bones. Okay. Here is -5. Baby's head is here. The baby is covered with what? Umbilical sac or the membranes. Okay. This is the umbilical cord connecting the baby to the placenta. Okay. This membrane has ruptured and the fluid leaked out. That is not a problem. Okay. Baby's head is high above -5. It means that baby is not ready to come out yet. So if I should take these membranes out, and it is now left with the baby and the umbilical cord, nothing is protecting it. What will happen? This long umbilical cord, some of them will what? Come down here. It's very long. Umbilical cord is long. It will come out here. When it come out here, it will come below. Yes, it will go below the head of the baby. There are so many bones here. Baby is coming down. The head of the baby can compress on the umbilicus. Yeah, that is another issue. I'm not talking about that. But when these umbilical cords become free and they are dangling in the uterus. It can what? Protrude. It can come out. It can prolapse down because the membrane has cracked. Okay. When that happens, remember I told you the umbilical cord has blood vessels. Okay. And it has what? Blood. Yes, it has blood vessels. And it is connecting straight to the heart of the mother. This baby here, the blood vessels are connecting straight. The only junction is what? The placenta. Okay. So if I have umbilical cord that has prolapsed and the head of the baby is compressing on it, it means that what? Okay, let me do it here. I have a heart. The heart is sending blood through the arteries to this baby here. The baby also has a heart. Okay. Along the line, something has blocked this artery. Do you think arterial supply will be strong? And if I check for pulse or heart rate, I will feel good, perfect bounding pulse. They are going to see irregularities in what? Heart rates. That should tell you that the baby is not getting blood. What are inside blood? Oxygen and nutrients. This baby will be crying. Can you, the mother, hear that the baby is crying? No. A baby inside the uterus of the mother, they also cry. They go through this stress. They become frustrated. But how can you know? The only way they communicate is fetal heart rate. Their heart rate. Okay. Yes. So you check their heart rate to know the irregularities. To know the irregularities. To know the irregularities. What can you do? Some people can what? Sometimes or most of the time, we elevate the presenting part. The presenting part, the head that is compressing on this, elevate it. Okay. One of you, the colleagues, can wear surgical glove. Push your hands here. The long, midwife, they have a long surgical glove that can even reach your upper arm. Okay. Yes. Put your hand here, go inside. The uterus is the mouth of the uterus or the cervix is wide open, 10 cm. Okay. Yes. So you can go, or even 5 or 6, or your hand can push through. Go and lift the head. When you put your hands here and you lift the head, the fetal heart rate will come back to normal. When you leave your hand, or when you remove your hand, the head will still hit on so what are you going to do? Keep your hands there until the doctor comes or until we take the patient to theater. Please, do we understand? This thing is not difficult. It's very cheap. Okay, but if you don't know these maneuvers, midwifery will be so difficult for you to understand. It's one of the cheapest courses on earth. Okay. Yes. You can also do your knee, chest, or Trendelenburg position. Then you call your provider start. Start. So anytime you hear any medical order that they push this 4-letter words to it, it means as soon as possible, immediately. Stop everything you are doing and call the provider. Okay. Yes. So until a provider comes and take over from you, the midwife or the nurse, or we take the patient to theater. Don't remove your hand, please. Let your hands be there. Okay. So I'm done with you for station. Keep your questions. after my presentation, you ask the question. Let's do effacement. Cervical effacement. Yes. The head is descending. What is keeping the head descend? The uterus muscles. They are contracting and pushing the head down. Okay. But remember, this is the uterus. Big uterus like this. Okay. The uterus has a mouth like you and I. It has a mouth. So this mouth, mm, it is very thick like this. This is how it looks like. So we have the internal os and the external os. Okay, internal os. And this is the body of the mouth of the uterus. The mouth of the uterus in medicine, we call it what? Cervix. Mm. As this uterus is pushing the head down, and the pelvic bones are opening, and the cervical spine is also opening, and the head of the baby is coming down. What happens to this thickness? Can the head of this big baby pass through this small hole? There's going to be a big trauma. Trauma here. Because the head of the baby has hairs. Okay. So what can we this service must what become short and thin. So in two ways, the length and the breadth must be changed. So what can we do? The uterus, the service of the uterus must what the length, this length, it must become what shorter, shorter like this, shorter, very short like this, very short like this. But the breadth is the thickness. This place is full of muscles and blood vessels all over. Okay. What happens to the bread? The bread must thin, it squeezes itself and it becomes so light and thin. That is it. When the length of the cervix shortens and the bread crashes and becomes so thin, in English or in medicine, we call it what? Effacement. Okay. Effacement. And how do we measure it? We measure it what? By what? Percentage. So you can see the length of, the woman, your cervical length now. So when the baby is coming down, this length will become short. So let me take some out. Mm. Or maybe we have to keep it. So this is the length and the breadth. So we can get a service that the length has become so small and the breadth has become so thin like this. With that one, this big head can pass through. So we describe it as what? Effacement. Effacement ranges from 0 to what? 100%. We need 100% before delivery. Those of you who are going to write NCLEX. So they will give you maternal health NGN question and tell you effacement is 40%. Are you ready to deliver? No. Effacement is 50%. Okay. So many things must come together to help the baby to come out. One, I need uterine contraction. This is the uterus. It starts from the head. The head of the uterus is called the fundus. The fundus must be hard. It must be hard. How about the body of the uterus? The body of the uterus must contract. So as they are contracting, that is where we call what? I mean, the uterine contraction, we measure them in those centimeters. Okay, so and so minutes or so and so seconds. Contraction should not, like seizure. The time contraction starts, the duration and the time it ends, and the interval between the end of one contraction to the start of one contraction. So we do all this one. We do the pathograph to measure them. So the uterus too is contracting. The baby inside the uterus must also help himself or herself. Okay. Yes, it must descend. As it's descending, it will come with all the station, effacement, engagement. Okay. So the head is coming down, descent. Station at the ischial spine, the boundary. Engagement at the 0 point. Now the head has to reach what? The cervix. It must come out. That's the last journey. When it gets to the cervix too must change in length and breadth. And when that changes occurs and gives us a full readiness, we call it what? 100% effacement. You understand? So it's a journey. Pregnancy is a journey. If you don't understand it, you always be confused. You always flip the notes. Okay, right? So 100% effacement plus increased station is equal to what? Birth approaching. Poor effacement plus strong contraction. Consider what? Labor dystocia. Very important. Labor dystocia. Okay. So baby's head is coming out, has gotten to what? The uterus is contracting. The head is at the cervical. The cervical is not opening. The cervical is not opening. What do we do? Problem has come. Labor dystocia. Okay. Now let's continue. So these are some of the things you should know. These are those of you who like a quick way of learning. We have the comparison table. All these things must happen. The mouth of the cervix, their small hole should open. The length of the cervix should what? Crash. And the breadth should become thin. Okay. Then we look at what? Station, the descent to. Okay. Now let's continue. So we have fetal presentation. I mentioned when we were doing a station, we mentioned presenting parts. So forget about this. When I used to teach those old students, anytime I get here, I stop the class to teach next day. So today, let's continue. Right. So let's look at presenting part. This is you. Okay. When somebody is not pregnant, the person has landmarks that divides the body into two. We have what? The umbilicus is here, one. And what else? Who can tell me? There are two things that divide the body into left and right and left. You are not pregnant, but still, we should be able to divide your body into two halves, right and left. One is the umbilicus, which every human being has umbilicus. Which other organ or which other body part do we use to divide the body into two? Yes.
The linea nigra.
No, I said when somebody is not pregnant.
The sternum.
Sternum will divide the body into two. It will get to the abdominal region and stop. So how do we divide the abdominal region? Yes, that thing is at the back of every human being. What's the name?
The spine.
Spinal.
The spine. Helps you to divide, helps us to divide your body into two. Okay. Once a woman is pregnant and the hormones start shooting up, the body will be further divided into two with a hormonal line that appears when there is high hormones, especially in pregnancy, and disappears after pregnancy when the hormones go down. And somebody said the linear hot, the linear alba, the linear gay, whatever, so many names. Okay. Yes. It divides the body into two. So what does it mean? The uterus is here and the baby is inside. So in effect, the body is more comfortable with everything that gets into it, and it aligns itself with what the centrality of the human body. Okay. So we have the horizontal presentation. The horizontal presentations aligning itself with the horizontal presentation of the main body. Okay. So the horizontal, whether it is your head that is coming or your leg, whichever way, once you are in that straight line, you are in horizontal presentation. Then we have the vertical presentation. Okay. Yes. So let's go down. When it is horizontal presentation, we have the cephalic, the head, cephalic coming. Then we have what? The buttocks, or whichever way, the breech presentation. Yes, this baby is horizontal, but they are presenting part. Okay, so when you are looking at what presentation, ask yourself, this is my line. Let me bring it here. This is my line. Is the whole body of the patient, of the baby, in line with this line? Yes, this is horizontal presentation. Then you ask yourself, okay, if it is the whole body, which body will first get into what? The pelvis. Because I have my pelvis here, and I must pass through here before I come out. This is the pelvis. I might pass through this pelvis before I come out. So all this body, the hand is here, the leg is here, the knees are here, the back is here, the head is here. The head, we have the frontal and the back. Which part got to the pelvis first? Which part goes to the pelvis first? That one too. If you look at it. Then we have the transverse guys. Okay, right. So, and we have the vertex presentation. So with the vertex, the back of the head. Okay. You see, this is the front of the head, this is the back of the head, entering the pelvis. Yes, this is a cephalic presentation, but it's vertex. Okay. So many pictures. When we go down, we will know them. The fetal presentation refers to the part of the fetus that enters the maternal pelvis first. So keep your question, write it down. When I finish, then you ask me, okay? Right. Now we have the main types. The cephalic, that's the most common. Everybody likes cephalic. Okay, it occurs in about 95% of births. Okay, then we have the vertex, the back of the head, like I showed you. The back of the head. And this is the front of the head. This is the back. We call it, yes, this is what? A cephalic. The head entered the pelvis first, but the back of the head came before this. So we call it the vertex presentation. Okay. Then we have the brow, the forehead. So you see babies with the forehead coming down. Then we have the face presentation. So the face. So we have the forehead here. That's the face. Okay. Yes. So these are some of the presentations, the safest. So this is complete. How do we call it? Breach. Then we have the incomplete. Okay. Then we have the frank. How do we know the difference? Look at this leg and the buttock. Okay. Yes, this baby has aligned itself horizontally with what? The linear or the midline of the woman. So it is a horizontal presentation. Now, which body part entered the pelvis first? We saw the buttocks here and both of these two legs. So we say what? Complete breach. Please, do you understand? Let me know if you understand. Complete breach. Now let's look at incomplete. The buttocks entered, the leg, one leg, and one leg outside the pelvis. You do ultrasound, USG, you know all these things. Okay, one leg is hanging outside the pelvic cavity. One leg is inside and the buttock. Yes, baby is horizontal. But the presentation makes it incomplete, breech presentation. Sisters, I'm here. Your hand is up. Is it a question? If it's a question, then you have to wait when I finish. So write it down.
Okay, no problem. Thanks.
Or you want to make a contribution? If contribution, cool.
I don't know whether it's a contribution or a question because of the how I'm making the presentation. The vertical and the horizontal that you are talking of, because from childhood we know that if you are standing erect, that is vertical, and if you are lying down,
yes. Sorry. Yes.
That's horizontal.
I exchange the English. Sorry.
I'm a bit confused. That's why I wanted to make the
So this is vertical. Sorry.
Yeah.
Yes. Thank you for coming in. This is vertical. And this is horizontal. So this baby has aligned itself vertically to the linear, to the midline of the woman. Just that the presenting part changed the whole story. That you will not try to deliver this baby. Otherwise, you cause issues if you are not experienced. Then we have the frank. So you hear midwife saying frank. It's a type of breech presentation. This is only the buttocks and two legs outside the pelvis. So you see where the legs are, the feet, and you see where the buttocks are. This is what we call what. So all these things, this is to help those who are not going to write any exams. It helps you to do your assessment on every patient. Okay. So I've explained them. The breech is the buttocks or the feet first. So you know when you take the slide, you should be able to know the differences. Okay. So the frank, the buttocks, the complete, the buttocks and the legs, everything inside. Then the footling or whatever. Okay. Yes. So what happens? There can be cord prolapse. There can be head entrapment. There can be birth trauma, which happens to a lot of. Imagine you are living in a clinic in the village and mother comes with, some mothers will stay home even when contraction starts. And they will come to the hospital when they hit the latency phase or the late part of the active phase. Okay. Midwife will try. It can cause a lot of issues for both the mother and what. So to be on the safer side, C-section for breech presentations. C-sections. Okay. Now let's go to shoulder. Somebody came with their shoulder. One side, shoulder. So shoulder transverse. Okay. This guy. Shoulder. That's where the doctors have problem. My shoulder. This is the pelvis. Okay. It makes you what? Lie transversely. Okay. In relation to the centrality of the woman. So we get the 90 degrees angle here, which is no good. And you will not try to deliver this woman vaginally. It cause issues. So a child is coming with the shoulder, okay, or the transverse lie. This is an obstructive OBGY or OB, obstetric emergencies. You can never deliver. You see the warning sign here, vaginally. So those of you who are going to write enter, when you see this, it's a safety concern. I've told you that NCLES is about safety. Always safety is the denominator. NCLES, safety is the denominator. So the question you are reading, before you even start reading the question, ask yourself that, or tell yourself, safety is my foundation. So whatever I put on top here as my numerator should support safety. If I choose answer A should support safety of the patient. Otherwise, the computer will punish you. Okay. Yes. So you go and you see a patient. Somebody is saying the screen is blurry. Is it blurry at your end? Let me know. Sorry, I just saw you. Is it okay now? Is it okay? Right.
Yeah, I think it is blame. I also think it's blame. But not too much. It's manageable.
How about this one? Is it okay? Who else can also confirm? I want to know.
It's okay.
It's okay now.
Yes,
perfect. So I'm also doing live stream on Facebook and YouTube. So if anything, you can also go and watch it there. And I'll leave the videos there. Okay. So you just follow me. Then you go and watch it later if you want to watch it. It's always there till Jesus comes. Okay. Yes. So let's continue. There is a high risk of uterine rupture and cord prolapse if you try to deliver this baby vaginally. So take note. You always prepare for CS. Okay. So we know the presentation, the line and the position, the differences, the lie, transverse lie, longitudinal, whatever. Okay. Yes, the presentation, the part of the baby coming or entering the pelvis, and the position is very important. Okay, so the position, especially with the head, we have the occipital anterior, the right occipital anterior, the left occipital anterior, whatever. Okay, so all these ones you should know. Okay, yes. So memory tricks, vertex, the back of the head is what V for vagina. Breech is the bottom. It's a big risk. Then shoulder is surgery. Those of you who want to know, these are some of the tricks when we're going to write NCLEX. These are some of the tricks we're using. Okay. Okay. Vertex presentation. Oh, okay. So let's do rupture of membranes. Because we need the membranes to rupture. Okay. It also helps labor to progress. Rupture of membranes. Okay. Mostly rupture of membrane in absence of uterine contraction, usually after 37 weeks. We consider it as what? Premature. Okay. I've told you that for baby to come out of the uterus, this muscle of the uterus must contract. And the membranes at a point in the journey will also rupture, it will burst. I have a membrane that has ruptured, but when I check the uterus is not contracting, or the uterus is giving me blasting X, false contractions. I will call this rupture what? Immature or premature rupture of contractions. A certain woman can urinate and come to the hospital that my membranes have ruptured. What do you think we can do to differentiate between amniotic fluid and urine? Who can tell me? Amniotic fluid and urine. Yes, who knows? Let's go.
Then you do pain taste.
You do what?
Pain taste.
Okay, so you're gonna do that your test. And what are you going to see? Yes. So you do the amniotic fluid test. Okay. It's like a litmus paper test. Okay. No. So when it changes color, you know that, oh, this one is urine. This one is amniotic fluid. Okay. Yes. So all these changes are there for you to know. Otherwise, you go and give somebody medication, okay, that you are not supposed to give. Sometimes, too, some babies will come out with the amniotic sac intact. So at this moment, we have to manually rupture it when we want the amniotic sac to rupture. Because when it ruptures, there are some hormones in it that also help the uterus to contract so that labor will progress. Okay, so we call it the amniotomy. You puncture it. So you see the hook. See that hook? That's yeah, this instrument. Yes, you put it inside with your hand, rupture. Okay, so these are all rupture of membranes. This is the breakdown of the amniotic sac causing leakage of fluid. It is best when it ruptures and the uterus too is contracting. Amniotic fluid is usually clear, pale yellow, or odorless. It can spontaneously or artificially be ruptured, be punctured. Okay. So these are the spontaneous that occurred on its own. Or this one, you did it. Okay. So we have the types of membrane ruptures. We have the spontaneous rupture. That's natural thing. It at best. Artificial, done by the provider, like we saw it here. This artificial rupture of the membrane. Okay. Then we have what? Rupture, premature rupture of membrane. That is the bursting of the amniotic sac before labor begins, before 37 weeks. Okay. And there is no contraction of the uterus. I have told you that this is the uterus. This is the baby. This is the amniotic sac. This is a protective shield. Okay. Protection against infection, 1. Protection against mechanical trauma, 2. Okay. Mechanical trauma, as in the fluid here is inside this balloon. The fluid is here, inside this space. Okay. And they serve as a cushion. So the woman, somebody can hit the stomach, some accident, everything. This one will serve as a cushion, protect the baby. Okay. Which woman has what? The lower uterine segment, which is what? Non-sterile. Some women will be dodging, some women will be inserting so many things which will help carry infections to the upper uterine segment. When bacteria or other microorganisms enter into the uterus, this amniotic sac, yes, the uterus can be infected, but the baby will be intact because there is a barrier here. But when this one breaks, fluid and all these things can enter and cause issues. Sometimes blood, so many issues for the baby, infection. Okay. So when it happens like that, that's why when people come with rupture of membranes, it's not time for them to deliver. We give what? ABX, antibiotics, and we give mother fluid. Okay. Then this is the 37, the premature is like premature kind of before 30. This is an infection plus what? Prematurity risk. So when those of you who were part of the class when we started, I told you that we have divided pregnancy into 3. The 0 to the 20 weeks, the 20 to 37 weeks, and 37 upwards. So this is the abortion phase. This is the prematurity phase. And this is the term or the maturity phase. So you ruptured your membrane in this phase, in these weeks, 20 weeks to 37 weeks. You will fall under this stage. Okay. You have 2 troubles, 1 gone. There is a higher risk that your uterus will start contracting. Okay, here. So it can cause prematurity or premature birth. Then also infection risk. Somebody entered the 37 weeks, okay, but contraction has not started and ruptured, let's say 37 plus 1 day. Okay. You ruptured your membrane. You went to the hospital. They did all the assessments. They saw that no, there is no contraction. They will tell you to go home. Going home means you're going to be at risk of infection for the baby. So we need to give antibiotics to create that protection barrier there. Okay. Yeah. So these are the things you should know. Signs of infection or confirmation of premature infection. There is a sudden gush or continuous trickle of blood. And the rupture too, we have two types. Yes, if I have a balloon and I use a knife to puncture the balloon, boom, it will burst. And when it bursts, the fluid will gush out. Okay. But if I have a small needle and I puncture, there's going to be a leak. So the mother will come to you. When I woke up, I saw a gash, or when I was walking, I saw a gash. That should tell you what has happened inside. If you should do all your scans and everything and know that, then you know that, okay, the rupturing here was just not a normal puncture. Okay. Yes. So feeling wet without urine odor is also part of the signs. So we have the nitrogen test. Nitrogen test. Then we have the Fennings test. How to know? These are the objective tests. So a mother will come to you with what? That Marcia 4. I'm feeling wet down below. Okay. It's not every fluid you see that it is coming from the umbilical amniotic sac. Okay. So you have to do these tests. Okay. So the nitrogen test, if it is amniotic fluid, because amniotic fluid inside the uterus, let me test you. Inside the uterus, is it acid or a base?
It's a base.
Base.
It's base.
When you take a woman's uterus, okay, we have the upper uterine segment and the lower segment. Okay. The lower is acidic because of infection, because of all this, because it is on sterile. The lower is always on sterile. Okay. And the upper is what? Sterile. Clean. No cleanliness, no dirt. I mean, jeje. Because the baby has to come from there. Okay. So it's a base. So when the fluid is coming from the upper segment, from the amniotic sac, and I want to test it using the nitrogen test. This one we do it in the lab. Okay. Or some of the midwives, they have some of the kits, they do it. It should turn this base what? It's alkaline. It should turn the paper. It should turn the test to blue color. Okay. Yes. Then the Fenning test. It's like a Fenning-like pattern on the slide. Okay. But because of cost and because of money issues, most hospitals like doing this one. We can also do ultrasound to check the amniotic fluid quantity. Ultrasound. The quantity, the volume. Okay, so when the volume has decreased, so they will look at how many weeks are you? I am 36 weeks. Okay, per 36 weeks, you are supposed to have, let's say, 500 mils of amniotic fluid. But NTAC is 36 weeks. The amniotic fluid is 200. What is the diagnosis? Yes, Messi, sharp.
Please, come again.
6 weeks. I have
Only
low amniotic fluid. What is the diagnosis?
oligohydramnios. Only.
Yes. Oligohydramnios. And when it's more than, that's poly. So all these things you should know. Okay. Then the pooling. This one, every woman will come and tell you, I'm feeling pooling, I'm having pooling. It's normal. Okay. Right. We've got 1 hour more to close.
Please, the
Some
screen still
people.
looks blank.
Oh my God. Is it better? Let me stop the
Yes.
share.
Yes, it's better now.
It will be better. Is it better now? Let me know the person who said it's Blair.
Yes, it's better now.
Okay. Right. So, Enclest trap, somebody who sees sperm, blood, infection in this fluid. These are all false positive nitrazine tests. Okay, don't go and say this is a confirmation of rupture of membrane. No. So take note of that. Okay. So when somebody ruptures the membrane, the first action, check the fetal heart rate. Because there is what? A high likelihood of what? Called prolapse. I have told you this. The amniotic sac, in a way, secures the umbilicus. It secures it, it holds it. Okay. From this part to the baby is holding it. Okay. Then this is the uterus. So what if something happens and this one is no more? You are going to get a long cord that will be what? Swinging inside the uterus. Can prolapse. Okay. When it prolapse, even when it twists, like kind of volvulus, it twists. You have twisted arterial supply and venous return. So what will happen to the baby? Baby can get distress. How will you know? Changes in fetal heart rate. Take notes. So these are the things you should know. Okay, fetal heart rate. So you assess for cord prolapse. That's the first thing to do, please. Assess for. So you monitor for your heart rate, the color of the fluid, the odor, and the amount. You check maternal temperature every 2 to 4 hours. You check it. For what? Why do we have to check temperature? Amniotic sac has ruptured. Yes, Mercy, shoot.
For signs of
Why do
infection.
I have to? For what? Infection. Good. Okay, good. Then you maintain side lining. Why side lining? And which side of the woman? Yes, Mercy.
The left side to facilitate blood supply and then oxygen supply to the fetus. Left
Baby.
lateral.
And to prevent aortic cover compression. The aorta, the inferior vena cava, their junction. You don't want to compress it. Okay. You maintain strict aseptic technique. So student nurses and people who are not nurses. Okay. And you allow them to go and do vaginal examinations on this woman with ruptured uterus, ruptured umbilicus. No digital vaginal examinations because you put it on a catheter. If you put it in one, you have introduced infection. Then you put it again, you remove, put it again, another infection. So you have introduced 2 infections. And give the person 2 weeks, they will come back with infections, especially the old people. So the pregnant woman, you do V1 infection, you've introduced. Then you do VE anyhow. Okay, you are causing trouble. Okay, so what are the major complications of pregnancy? Umbilical cord prolapse, we know this. Okay, you can do your so high fetal station, breech presentation. All these ones can cause umbilical cord prolapse. Okay, so signs and symptoms: fetal heart rate is going to get decelerations. Remember your V chop. Okay, then your palpable cord. So your knee chest position, elevating the presenting part and holding it until the doctor arrives or we take the patient to theater. Then you prepare for emergency C-section. Okay. Now, somebody's
Bright, please, the
I'm not.
screen is so blurry.
Is it better?
Not yet.
Is it better? Okay, I know what to do.
It's better.
Let me take this one out. Okay. Is it okay now? Another major complication, please. Is it okay? Let me know so that I continue.
Yes, it's okay.
What? Okay. Another major complication we can also take note with
It's okay now.
baby coming out is what? Infection. Where is the infection? Let's look at what? The chorioamnionitis. Chorioamnionitis. Okay. So I have my uterus here. I have my amniotic sac. I have my baby. This is the cord. This is the another cord, placenta. Okay. When I enter into the uterus of a woman with a baby inside, there can be infection here in the inner lining of the uterus. What is the name of that? Who knows?
Endometrium.
Come
Endometrium.
again. Endometrium what? Endo what? Infection of the inner lining.
Endometritis.
Endometritis.
Endometritis. Okay. I have an infection of the amniotic sac. It can affect the fluid. Okay. I have an infection of the amniotic sac and the fluid, sometimes affecting the umbilical cord here. We call it the chorioamnionitis. That is why, I don't know, this part of the uterus is always sterile, but still, you see pregnant women having infections entering here. What is happening in the community that the health workers don't know anything about? Okay. So when that happens, there is fever, definitely. Foul smelling fluid, amniotic fluid, maternal and fetal tachycardia. When you see tachycardia and infection, what does it mean? Yes.
What is it? So come again with the question.
Come again.
I didn't understand the question.
When you see tachycardia and infection, What does it mean?
It's an
Enrichment.
indicative of shock.
Yes. You are nearing, you have started the journey of shock. Okay, septic shock. So when you see this quickly, what do? You check what? The blood pressure. The blood pressure. And you know the funny thing, when the tachycardia starts, when the heart rate starts going high, the infection is inside the mother going on. It will start, baby heart rate is going up. The mother too shooting up. Okay. Check the blood pressure of the mother. Your fluid resuscitation, very important. You take your blood samples, okay, for the sepsis protocols. Do everything. Then uterine tenderness. Uterine tenderness, very hard and tenderness. Okay, that should tell you that no, infection trouble is coming. Okay, so you give antibiotics. Looking at the stage of the age of the pregnancy, the weeks, you can prepare for delivery. If I hit you 35, 36, I will deliver the baby. I won't wait for you. Okay. Yes. So we know the rupture of the membranes. We know the urine, whatever urine, Kukwasa guys. Okay. Urine is always acidic. So you should know, and the amniotic fluid is alkaline. Okay. Yes. So you do your nitrogen test. So that is what you should know. Okay. Then somebody's uterus or the umbilical sac has ruptured 37 weeks and more. You can, let me put in the word can, allow the pregnancy to progress, give antibiotics, give fluids, monitor. Okay. 34 to 36. Can this pregnancy survive? So 34 to 36. You have, let's say it happened at 34 weeks. So 35, that is another 1 week. 36, another 2 weeks. Still, you are in the zone of prematurity. 37 weeks. Okay, how many weeks now? 1, 2, 3. You are battling with infections, which is very high. You are battling with fetal distress. Okay, so what are you going to do? Remember, in the prematurity phase, I always say 2 troubles, 1 God. You are battling with infection and prematurity because the heart rate of the baby cannot and will not always be patient for you to travel all this journey through these weeks without giving you changes. So as an anesthetist and as a midwife or as a doctor, what are you going to do? Yes, I've given the antibiotics. How about the heart rate of the baby? Okay. There are some women, they will get to 37 weeks, labor will not even set in. Some even go to the stage of 40. Don't even try 40. 40 is too far. Okay. So you can play around again, 35, 36. Okay. Hit 36, but I can deliver the baby. At this stage 2, membrane have ruptured. The hormones inside amniotic fluid is inducing the uterus to contract. Okay. But this baby at 34 weeks are the lungs, inside the lung, your lung, because you and I, we are old. There is a certain fluid that we use to plaster. You see, how do we call it? When you take bread You see, you have spread, you margarine, you spread it through. Okay. Yes. When you go to the uterus, the lungs, inside the lung, we have the alveoli. So inside the alveoli, there is a fluid that we use, the margarine fluid. We used to line it. The name of the fluid is called what? Surfactant. How does this surfactant mature? They mature in the presence of steroids. Okay. If baby is too young, where do we get the steroids from? Steroids are coming from which part of the body? Who knows? Yes, Mezi. I'll mention your name. Steroids are coming from which
The
part of the
adrenal
body?
gland.
The adrenal gland. Which part of the adrenal gland? This is the adrenal gland.
The cortex.
The cortex. The cortex. This baby is 34 weeks. Is this adrenal gland mature to give enough steroids to the lungs? No. Okay. So if you don't have enough steroids, the surfactant level will be very low. What does surfactant do? When oxygen gets here to the alveoli, the surfactant will help the alveoli to get a good surface area, smooth, so that what it can cross. You are going to deliver this baby at 34 weeks without giving steroids and without maturing the surfactant. Okay, be ready to help the patient with water oxygen. So we can buy time with antibiotics and IV fluid. Give the steroids to mature the surfactant quickly. Then 36 to 37 weeks, we deliver the baby. So it's a cascade of care. I should know. Okay. It's a cascade. Then the ultimatum, you monitor this baby. I have seen a baby who was born 21 weeks and was kept in the hospital till 37 and above weeks before the mother and the baby was discharged. So they kept this baby incubator. The baby is still alive in this US here. Okay. So when you are pregnant, just pray that you cross the 0 to 20 weeks, enter the prematurity phase. If the hospital or the country you are living, they have the resources for you. No fears. Move. Okay. Let's do postpartum. We have 30 minutes to go. So I'm using 20 minutes for postpartum and 20 minutes for the rest, and 10 minutes for questions. Quick. Write your questions down. So postpartum, baby is born. Okay. What are we going to do? So with the pregnancy journey, your fundal assessment, okay. The fundus, now baby is out of the uterus, but I still need the uterus to be firm. Where do I touch? If you want money from a man, Erega, what is this formula? You touch the head of the man. That's it. Okay. If you want money from a man, do things that the head will suit him. So if it is the uterus, this is the uterus. The uterus has a body, it has a head, and it has a mouth. I want this uterus to contract and be firm. What do I do? Touch it. Always see the uterus as a man. Say good things that the head will suit him. So you massage the fundus, the upper part of the uterus. Okay. Remember, When we started, we said out we want the uterus, everything inside the uterus, and the body should be in that vertical position. They should align themselves. Okay, so this uterus should be in this vertical position to align itself to the centrality of the body. How can you make it so? The uterus can only assume this position when it is firm. So you massage it to be firm. In front of the uterus is which organ?
Bladder.
Yes, Mercy.
Bladder.
The bladder. Okay.
The bladder.
Behind the uterus is which organ?
Rectum.
Rectum.
Rectum. Yes. Okay. Now let's go and see what these two guys can do to the uterus. The baby is out. I have massaged the uterus. The uterus is still de-aligning itself from the centrality. Okay. So let me delete the uterus now. Okay. I'll keep the bladder and the uterus and the rectum. I'll draw my midline. I will draw the uterus. This is the mouth. This is the body. Okay. When I got to the head has sugared. The head part of the uterus has moved away. This is the right side, and this is the left side of the body. It has moved away from the center of the body. It is no more midline. This is the word. They will use this word to confuse you. Don't worry. We catch them. Medicine is sweet. Okay. It has moved. What is causing it? Remember, the blood is sitting here. When the bladder is full, okay, first I have 200 mils of urine. The bladder, it has moved. I have 300. Bladder is increasing the volume of the urine. Okay. I have 400. Now the bladder has become big. It is pushing the body of what? Against the body of this uterus. And when that happens, it will sugar the head like this. What do I do to relieve pressure on the body of the uterus so that the head, even though I'm massaging it, but it's still tilting, deviating from the center? What can I do to bring this back? I have to first relieve the pressure on the body here. How do I relieve the pressure? I have to make sure the size of this bladder comes back to normal instead of becoming big. What do I do? I have to empty the bladder. Okay. This woman just delivered is on the delivery bed in the lithotomy position, like this. Okay. This is the issue going on. This is the bladder. Will I tell this woman to get up from the delivery bed and go to the washroom and urinate? Which midwife will do that? So what do? I pass catheter,
Straight catheter.
empty the bladder. You understand? You pass catheter to empty the bladder so that the uterus will be free. Now, let us massage the uterus again. You see the uterus coming back to the center. Sometimes you can top it up with some uterotonics, this oxytocin and all these. Right? Give it a little. Sometimes you can even give a little oxytocin. So I remember we used to give oxytocin, small dose, to the body of the uterus. Contract it, bring the head to the center. Life goes on. Nursing is one of the cheapest course on earth. Okay. Let's go. So they say uterus that this time around the head has shifted to the left side. Now who calls it is the rectum. What is inside the rectum? Feces. Will I tell this woman to leave the lithotomy bed and go and poo-poo? No. So you're gonna do your manual removal. That's it. So postpartum, you are still on the journey. You've done your fundal fundal assessment. Okay. Then it is believed that every day it should descend down. So as your hormones are descending, decreasing, the head of the uterus to be descending. It has to come back to what? Your pelvic bones. Okay. Yeah. So these are the things you do. Then we have the lochia. Yes, the blood. Remember, inside the blood, I have 10 minutes to stop lecturing. We continue tomorrow. So inside the bloodstream, remember, I have what? Red blood cells. I have what? Plasma. Okay. And I have the white blood cells. I have the platelets. That's how you spell platelet. Platelets. Okay. Yes. This one will make the blood red. This one will make the blood like yellowish or serous. Yellowish. This one will make the blood white. And these are the clotting friends, plus the fibrin and all those stuff. Let's concentrate on these three. This uterus, baby is out. But when baby was coming, remember, baby has hair. We got trauma. We get so many things. A lot of maneuvers are going on. So all these blood vessels here, they will take time to what? To clot or to stop bleeding. How do they stop bleeding? How do they stop? When the first to stop or the first to be controlled in this blood vessel cascade is the red blood cell, number one. Okay. It makes what? The blood red. Let me put it in here so that you understand the last part. Let me say goodbye for today. It makes the blood red, the red blood cells. Okay. Will you tell your wife when to deliver, Yarika? Now you are back home. Okay. You are still seeing red blood cells leaking out of the bloodstream to the pad. Once the red blood cells finish, they will finish. Okay. So the first to be controlled is what? To stop the red blood cells. So we give it first 72 hours. We need to stop it. Otherwise, we get anemia. You have to stop it. Yes. We are more concerned about the red blood cells. We are more concerned about the red blood cells. Okay, so at first, it was 500 mils of blood that was coming out. Out of this 500, 200 or 250 was for red blood cells. 250 was for these guys, other blood products. Okay. As you control the red blood cells, the red blood cell level will go low. So let's say red blood cell is now hot, 150. And these guys are 250. You realize that when you mix this blood, the color will not be thick red or bright red or dark red, the red blood cell amount, the concentration has reduced. So the color of this fluid will go down. It will change from the red you saw first time to what? Pink or brown. That should tell you that the red blood cell amount is reducing, though the plasma and the white blood cells are still there. Okay. The platelet and the fibrin, they will be working underground, gathering themselves, causing all this fibrin mesh, all this clotting cascade, and all. I mean, the liver will be bringing the bone marrows, will be, everybody will be helping to stop the red blood cell. So at the point, all the red blood cells will be out of the system. We will get zero red blood cells. Sorry, not out of. All the red blood cells will be blocked from leaking out. When they are blocked, the woman will still be wearing pad. When she removes the pads, you see fluid on the pad. What is the color of the fluid? No, there is no red blood cell. And if I fetch blood and I take red blood cell out of it, the color of the blood can never be red. And I say, you either see the plasma part, that is the yellow part, or the white blood cell part, that is the white side. That's it. I have been for so many days, I'm still seeing red blood cell, red blood cell, red blood cell. Or do I still have to stay home? No. I need to go to the hospital. The first 24 hours, the first 1 hour after delivery, the first 72 hours, these are the things you should monitor. Okay. Infection will come after 72 hours. We are dealing with blood products, a combination of all the blood products. Yes. Because this red blood cell, they carry the hemoglobin. And this hemoglobin has iron on it. Okay, that helps it to carry what? Oxygen. So if these red blood cells get lost in the blood through delivery, it means you are losing iron, and at the same time you are losing hemoglobin. Okay, this one will give you iron deficiency anemia. And this one, patient will be struggling to breathe, saturation will be dropping. So if I control this, the plasma is just the water part, the cells. It is just the water part. Okay. It is on top of the plasma that the blood cells, they swim. So we say blood is a connective tissue. Yes, the plasma will help you to swim. If I go to north and I put a leaf in a river, on a river, because the river is flowing, it will move the leaf from the north to the south. Those days when somebody wants to post letter, they will put it on the sea, and the sea will carry it to another country. That is the function of the plasma. It is a connective tissue. It connects, it takes information from one end of the bloodstream to the other end. Yes, I need blood to go to the liver. This is the heart. This is the liver. This is the blood vessel connecting it. I need red blood cell in the liver. How do I get red blood cell here? I need the plasma to serve as a river on which this red blood cell will swim before it gets to the liver. That is the only thing you can sometimes find, and not sometimes, always find in the plasma is what? The clotting factors. The clotting factors. Okay. The clotting factors, whatever, factor 1, factor 2, factor 3, those ones that helps, the liver will produce the clotting factors. they will put it in the river and they help. Okay. Yes, the clotting factors will come. Other than that, so somebody has lost plasma. Okay. Or we do a full blood count or complete blood count. The red blood cell is normal or whatever is normal. Okay. Or another scenario, a trauma patient has been brought to the ER. Massive blood transfusion. You are giving what? Total or red blood cell. Okay. You've given a lot of red blood cells. It will thicken the blood. I've given red blood cell. I punctured your IV and I've given red blood cell. What fluid will move the red blood cell to where I want it to go? I need the plasma. That is why after massive blood transfusion, we give what? Plasma concentrate. These are all tricks that you should know. Guys, time is up. Now let me open the floor for questions. I want to make it short so that you understand. Tomorrow we finish this slide. Tomorrow, next Wednesday, we are going to do maternity 3. We are looking at the pharmacology aspect, and we dive deep into more obs and gynae conditions. Okay. By Thursday, we should finish with everything. Then I say goodbye to maternity. The next one. Now, a baby has been born. After maternity, we are doing pediatrics. So growth and development and all those pediatric conditions you do. This is a free class. Enjoy, my guy. Okay. So questions? Any questions? Any questions so far? I saw some hands up. If you are still there, let me know. You always have to learn. Don't learn because of examination. Learn. Okay. Yes. Because you call yourself a health worker. You always have to learn. Don't learn because you want to travel to Australia. Yeah, Suleiman, Hamza, shoot. Your hand is up.
Thank you very much for this wonderful lecture. In fact, your lecture is precise. Are we privileged to your slides? How like precise you have done? You prepared it. Hope you better get it.
We have a WhatsApp page. I don't know if you are there. We have a
Yes.
WhatsApp page. We put all our slides there. For the videos, you can see it. You can go to, Ayariga is the coordinator. So he'll put the link on the Ayariga. If you can repost the link to the chat box. So those of you who have joined, and you can also put the link on the various platforms. So you join the WhatsApp group. Yeah. So we put the slides there so that you can, and we've made it simple. This is just 21 pages. Okay, for maternity 2. And we've made it in a PDF form. Okay. So I mean, wherever you are on your bed, you can learn. When you are sitting in a car, we always make it PDF. But every device in this world accepts PDF so that you can learn it. Learn for me, please. Learn for me. And like I said, I'm open to. I'm not working alone. I work with a team. Okay, I work with a team. I only do the presentation. The team prepares the slides, everything. We sit down, we analyze it, we discuss backstage what to do. Then I do the presentation and the other aspects. Okay, so if I am not there, another team member can take over and do presentations. Yes. Our aim is to help everybody. It is a philanthropic project we are doing for the world. Our target is beyond you. I want you to understand this. Our target is beyond you. Okay. We want you to develop yourself medically. That you should love your job and marry your job. Okay. You should go beyond that. So please, if you join, you share the page to someone to also join. Okay. So that everybody will learn. Where are the student nurses? You are learning. Join, come and learn. Okay. If you have any student organization you want us to teach them, you have any religious body, you can organize. Okay. You can call me Paul or Bright. Bright. I want your team to come and to organize this topic for our group, our society, our church, we'll do it for you, make life simple for you. Everybody should enjoy. I started this project since 2011. Okay. I used to teach every 30 minutes in my church. Okay. In Kibi government, in Kibi hospital, Kibi. There was a radio station, they used to call me. I do like 5-10 minutes presentation for health related topics. So we've done this over and over and over, so many years. Yeah. And now we want everybody to enjoy. And what yours is to join and just develop or increase your knowledge. That's it. Any question? So Yariga has posted the links to the page. Join. Make sure you are part of all the platforms because you don't know what will happen. Sometimes we do town hall meetings. Okay. Town hall meetings. That's when I have time. I can do some 30 minutes or 1 hour town hall meeting. We will call ourselves. Okay. Now let's take a topic. We can take the other time we did sepsis about almost 2 weeks ago. We did sepsis town hall meetings. Okay. So if you had any condition that is bothering you, tell me, message me. I'll organize a town hall meeting for you that people will join and we will share. So we can take hypertension, learn everything about hypertension in the space of 30 minutes to 1 hour. Then we leave. And you really enjoy it. So these are all the things we do. Okay. Guys, any more questions? If your hand is up, you can talk.
But I have a I have a concern small.
Okay.
The beginning, I couldn't join early. I don't know if it is okay for you to just help me out with that. The early part of the today's lecture.
I'm coming. Yeah. So which side? Because the time is over. I don't know if you want to
Okay.
go and watch the videos.
All right.
Yeah.
I think
Thank you. Right. So this is just a 1 minute brush over. So we started with filter station.
uh-huh.
Okay.
Just
We
about
went through the
that.
yes. So
Just
this
the
is where we
slide.
started from.
Because this slide. This
With the
slide.
engagement.
Yes, please. This slide.
Yes. We did engage. So it's not difficult. I mean, this is the uterus. The baby can never come out without the uterus contracting. So when you want to do labor, uterine contraction is 1. Okay, you study it. Contraction, always see contraction as seizures. So seizure will have a starting point, the time the duration, and the ending point. And in between So another start will come. So in between this space, how many minutes, how many hours did it take for us to get another contraction in the same? Okay. So the uterus is contracting, it's doing its work. Okay. The baby inside the uterus must also do the part. So the baby too will descend, will come down. Okay. That's the descent. It will come down. Okay. As it is coming down, it will meet structures on the way. Let's say it enters into the pelvis. It will meet structures. Which part of the baby entered the pelvis cavity first? That is the presentation. If it is the head, fine. Inside this uterine cavity, there is a small space that we call the ischial spine. This part, this head will enter into the ischial spine. The top part is the negative part, and the down part is the positive part. And the middle of this spine is the zero part. Okay, so when it gets here, or when it starts entering into the ischial spine, we call it what? Station. Once it starts entering into this zone, we call it station. But when the head gets into the 0 point, we call it what? Engagement. Okay. So it will do all the engagement, enter into the positive, start coming out of the positive. If it gets out of the positive, now it has gotten into what? The service. The service too has what? A length and a breadth. Okay. So for this head to peacefully pass through this service, this length should become shorter and this breadth should become thinner. When that happens, we call it effacement. It is a journey. Okay. It's a journey. If you don't know the anatomical structures of this journey, you can never understand maternity. Okay. I can teach this over and over, and if I wake up and I sleep, I will know. If you tell me what is station, I know what is station. What is effacement? I know what is effacement. And everything has to. So in station, we measure with what? The number line, the negative and the positive. In effacement, we measure with what? Percentages. Okay. And everything, see, let me tell you something. This station must reach the maximum level before it can progress to the service. So until station gets to +5, it cannot get to +0 and jump +0 and enter the service. The head must definitely pass through the +5 before you enter the service. And when you enter the service too, the service, it's the orifice, this mouth, this hole here. So if this is the service, this is the thickness, this is the breadth of the service. And this is the breadth, and this is the length. The length is becoming shorter. The breadth is becoming thinner. What about this hole? This hole. This hole is what we call the cervical dilatation. That one started when the uterus started contracting. Okay. The cervical dilatation. So the cervix, the mouth, or the inner chamber will become big. The breadth will become thin. The length will shorten. We call it what? Effacement. So until the effacement reach 100%, this baby can never come out. Okay. So this one, you should not chew it. You should not learn it. I mean, it is something you should know. It should be on your fingertips so that you know. Okay. Thank you. Any question?
Thank you, sir.
Any question? If no question, our time is up. Done 2 hours, 4 minutes. Thank you so much. We meet
Okay,
tomorrow.
thank you.
Okay. So,
Sir,
stop
thank you
all.
very much. Thank you very much, sir.
You're welcome.
Hey, thank you very much. We really miss you. Thank you very much, sir.
Thank you very much, sir. God bless you.
Hey,
You're
Sena, we are
welcome.
putting up
Thank you,
a
Sir Bright. Thank you so much. God bless
Thank
Sir,
you,
you.
Sir
it's,
Thank you,
Bright.
sir.
sir, it's Nicola.
God
So it's
bless you,
Nicola
sir.
that is speaking.